Today we'll have a ward round scenario discussion on bust abdomen. This is a very common scenario given in ward round. So, Professor Shivajyoti Ghosh, who is a professor and head of surgery, will be the teacher today. And Dr. Behrul Luda is supposed to join. He's a third year the NBA student at Garden Reach South East Hospital. As he has not joined, Dr. Prosenjit will answer initially. So I give you a scenario, Prosenjit. A 45-year-old gentleman underwent laparotomy for peptic perforation. On 5th post-op day, he complained of wound discharge and he has sensation that something has been given away. And he is complaining of pain abdomen on 5th post-op day. So how will you proceed, Dr. Ghosh? This is a scenario and patient has this discharge from the wound and he has got some feeling of something given away in the wound. So how will you proceed?
Sir, first of all, I remove the dressing of the wound and check the local collection is there or any induration is there. If is collection is there, we have to remove a few sutures in the wound site.
This is
And
Prasenjit, this
yes,
is a scenario of bust abdomen. I
yes, sir.
given you a scenario.
Yes,
So
sir.
managing patient will not be just straight to opening the wound. You have to assess the patient first.
Yes, sir.
Okay.
Yes, sir.
So I just want to add some point that basically ward rounds means that you'll be examining the patient in front of the examiner. So what we usually do in the wards, that those steps you are supposed to follow, right? So whenever we see a patient in the ward, we first it's better to greet the patient because examiner is there and you are appearing the examination. First greet the patient and then ask for the the complaints, how the patient is doing, how he's feeling, if he has any particular complaint, and then you go to the local examination or whatever examination you want to do. So this part is very, very important. Like any long or short case, you first take history, then you go to the clinical examination. So that way you should proceed always in ward rounds particularly. Okay, go ahead.
Yes, sir. I have to take the detailed history, the uh, the peptic.
Some of these I've given you. He is a patient of perforative peritonitis who underwent surgery 5 days back. So this is a patient who underwent emergency surgery number 1. He
Yes.
has a perforative peritonitis, so it is a potentially infected case. So on 5th posterior day, this is happening. So this is a classic situation where in 5th to 7th day, patient may have wound dehiscence or bust abdomen. That is the thing you should strike your mind. Okay. Now you said you'll open the dressing. On opening dressing, you find that a loop of gut is popping out. What should be done next? What are your step now? On just lifting the dressing, you find that a small gut loop is popping out in the wound. So what has happened?
Sir, there is breach in the sheath, and the sheath is
So
open.
this is a classic case of bust abdomen. That
Yes, sir.
means, how do you define bust abdomen? What is bust abdomen?
Sir, vast abdomen indicates the peritoneal breach from and the intra-abdominal content are popping
Why
up.
only peritoneal breach? You are seeing the gut loop outside.
Yes, sir.
So if you say bust
See
abdomen,
that.
a classic bust abdomen is one where there is dehiscence of all layers of the
All layers of abdomen. Yes, sir.
dehiscence of all layers of the wound. That is a classic bust abdomen. What you are trying to say, I will ask the next question. What do you mean by concealed bust abdomen? What is concealed bust abdomen?
In other words, how do you classify wound dehiscence?
Yeah.
If you know what the classification of wound dehiscence, you can answer this question. So basically, wound dehiscence may be superficial all deep, and usually by vast abdomen means the giving away of the inner layers, deeper layers, right? So if the skin is intact and if the inner layers are given away, so that is a kind of concealed.
Concealed busted. You cannot see the gut, but the wound has dehisced. So that is a concealed bastard. So now you have this patient who has got this gut popping out, and now you have to manage the patient. What are the steps in management? On fifth day, patient was on liquid diet. He was recovering well. Now what do you do? Is it what? Is it a surgical emergency or no?
Sir, first of all, we have to manage the patient in conservative way. Uh, the
Tell us what you do. Not all patient will be for conservative. There are some situations where uh, you see the gut loop is protruding out,
Yes, sir.
and you have remaining stitches. So what are the things you do now? He was on liquid diet. He was recovering well. Now this has happened.
Yes, sir.
What will be the consequences if you don't do anything? Then what will be the consequences? What will be the problem in the guts coming out of the abdomen?
Sir, gut if gut is exposed, there may be development of features of peritonitis and a local systemic infection may develop, uh, which
No, no, that were, I mean, late consequences, maybe, but main problem is that the patient may have dehydration. The amount of gut is exposed. So, I mean, the body fluid will be, uh, there will be chances of dehydration. So that is one issue. And second thing is that if the guts are exposed to the exterior in long course of time, there will be fistulization formation,
yes,
right?
sir, intracutaneous fistula may develop.
And subsequently all other metabolic changes can occur other than the
Yes, sir.
infections and all. So we should try to uh, preserve the normal anatomy as much as possible, as early as possible. So
And
for that,
another predictive factor for bust abdomen is patient may have a distal obstruction, and the gut that is popping out may be coming out through the narrow dehiscence area. So what can happen is there may be constriction at the neck of dehiscence. So this is a surgical emergency. Once
Yes,
you find this, you have to manage the patient as a surgical emergency. And then, as I said, patient was on liquid diet. What do you do? What are the steps in management now?
sir, we have to NPM the patient.
Yes. Give needle
Right,
orally. Start him on IV fluid.
IV fluid,
If you feel that the stomach is distended or he has history of vomiting, you should put the patient on nasogastric tube.
nasogastric tube. Yes, sir.
And you said conservative. Conservative is not the norm for all patients. The norm is to take the patient for surgery for repair of the bust abdomen. But if the patient condition is very sick, patient is unstable, you cannot take the patient to the operation theater. Then only you treat the patient conservatively. Otherwise, the idea of treatment of bust abdomen will be urgent repair.
treat in a sense that you should resuscitate the patient, and when the patient is fit to withstand the anesthesia, then you will have to take the patient to the operation theater for the repair. Okay, so I mean, Professor Shah has described it nicely. So that is the main goal of treatment of burst abdomen.
What do you think the predisposing factors for wound dehiscence in a post-op patient? What are the different factors you keep in mind and then try to address those factors?
So the general condition of the patient, that
You divide,
patient may be
you divide. There are some patient factors. There are
patient
some
factor.
surgical factors, the technical factors. So many things comes in a patient who has got bust abdomen. What are the patient factors which are important for uh, wound dehiscence?
Sir, general condition of the patient. Patient may be anemic, maybe jaundice, hypoproteinemia may be there. It may
Yeah.
be due to malignant disease. The technical factor would include types of operation, types of incision, type of operation, operation for peritonitis. or
Yes.
operation on pancreas associated with
No, no.
post-operative
We
Yes,
are
sir.
we are discussing this patient. If you take this patient, you say some patient factors like patient might be anemic,
Yes, sir.
hyperproteinemic. Okay.
Yes, yes, sir.
Then
So just
Then, sir,
one point here, if you remember these factors, these are same factors which are predisposing factors for the development of incisional hernias, right?
yeah.
So if you read this nicely, I think a long case like incisional hernia, you will be well prepared.
Yeah.
Many
yes, sir.
things are in common.
And then if the patient has got post-op cuff, patient
Yes,
has
sir.
post-op abdominal distension.
Abdominal distension. Yes,
Patient has abdominal distension because of paralytic ileus or some form of distal obstruction. So these are the
yes.
patient who may have the wound lesions. And what are the technical factors? When you are doing the surgery, the surgeon technique in closing the abdomen may be a factor for the wound lesions. Which
Sir,
wound
the
is more?
mass closure of the abdominal wound has lesser incidence of burst abdomen.
Yes.
And if we prefer interrupted suture, have lesser incidence of burst abdomen than when continuous suture is applied.
What about suture materials?
If absorbable suture is used, it leads to the higher chances of.
Now, see, you have to specify. Now, most of the people are closing abdomen with PDS, which is
Yes,
delayed absorbable suture, which is
delayed
very good.
absorbable. Yes, sir.
Which is very good. This has become alternate to a polypropylene suture for a midline closure even.
Yes,
So
sir.
you have to use the term except delayed absorbable, like PDS, that can be used. That does not cause higher incidence. The technique are important. If you suture and suture the abdomen under tension, okay, you are suturing and making it too tight. Okay.
Yes, sir.
What is Jenkins rule while you close the abdomen? What is Jenkins rule being applied?
Uh,
Jenkins rule. While closing the abdomen, you are using suture. So whether you are making a proper bite, whether you are
Sir,
maintaining
0.5 centimeter gap may be present between two sutures.
that is one. So the gap should be 5 millimeter and
Yes, sir.
distance for the margin 5 millimeter. And
Yes.
Jenkins rule says that while
One.
closing a wound, you should use 4 times suture
Yes, sir. 4 times suture.
in comparison the length of the wound. So
Mm.
if you are not doing that, then you are not taking proper bite or you are pulling the suture too much so that you are using less suture. So Jenkins rule should be applied while you are closing. You should not close it too far or too near. You should not do the suture under tension. Okay.
Yes.
Right. So what are the precautions you will take? Suppose you are closing an abdomen and expecting that this patient might have burst abdomen. So what are the techniques or points that you should keep in mind while closing the abdomen?
Uh,
Suppose it's an infected abdominal wound, like say gangrenous intestinal obstruction. You're about to close.
Sir, we have to close in a tension-free manner. Uh, uh, we use delayed absorbable suture and
Would you like to have continuous stitches or would like to have interrupted stitches?
sir, interrupted stitches may preferred. Sir.
Right.
Have you
So
heard of any suture which has been claimed to have less incidence of this lesions, even in interrupted? There is this suture is devised by AIMS people. They have studied and they are trying to say that if you apply suture like this, the lesions will be less. They are describing this as a far near,
X stitches.
near, far near. Okay.
Yes, sir.
Right. And any other options or points that might have uh, preventing wound infection or burst abdomen. Wound infection is one of the predisposing factors, right?
So you have to prevent wound infection.
Yes, sir. So we have to manage the post-operative complications like post-operative staining, like coughing, or if vomiting is there, we have to treat that. Post-operative, any intestinal obstruction is present or not, we have to rule out that.
So delayed sutures, delayed closure, delayed
Yes,
primary
yes,
closure, right? So that is
yes,
one option. You can tie the fascial closures and keep the skin open, right? And
yes,
after 4-5 days, when you see the wound is healthy, then we can close the skin. This is another way of preventing wound infection, thereby wound lesions. Right. Suppose you are closing one abdominal wound, which is really very full of pus and other uh, intra-abdominal condition is very, very infective. And you can't easily close the abdomen. Then what are the options you have? It happens sometimes. The gut is so edematous, dilated that you can't close.
The risk of compartment syndrome if you close
Yes,
the
risk of
abdomen
complication. So what are the
and grossly
options?
infected. What are the options?
Once in a while you will face this problem. Have you heard of silo or Bogota closure?
yes, sir. Bogota.
Yes. So what are this?
Uh, a Bogota bag is placed and to cover
So
the
this is a condition of we call as open abdomen.
open abdomen.
Okay, so here the idea will be not to close. As the scenario Dr. Ghosh has given is a all factors which might lead to dehiscence or compartment syndrome. So you will decide not to close the abdomen. So if you decide not to close the abdomen, how do you come out? You said Bogota bag. What is Bogota bag? What do you do? You have seen this in the ward. What is this Bogota bag about? Ranjit?
So
Sir,
yes.
Yes.
uh, Bogota bag, sir, is covering the we left open the skin and the sheath, and we covered that, and we fix the bag through the sheath, and close the temporary closure of the intra-abdominal contents. Cover the
It's not
entire.
it's not a layer tool. Sorry. You apply a plastic sheet. It's
Yes, sir.
maybe a open Euro bag. You
Yes,
switch
sir.
it to the margin of the wound.
Yes, sir.
Okay, so the margins of the wound are not opposed. You bridge the gap of the wound by placing a plastic bag so that the guard does not remain exposed. If the
Yes,
guard is exposed to the dressings, the guard might get injured. So
yes, sir.
you cover the wound with a plastic bag. That is a Bogota bag.
Yes, sir.
Right. Even if these things are not available, usually plastic bags or the Euro bag is available. But this is one option. And what is the other options?
Sir, we may use wound manager bag to cover the wound and uh, protect the intra-abdominal contents, sir. And
Well, sir.
hello.
So idea is to cover the abdomen, right? If
Yes,
nothing
sir.
is available or is
Yes,
not, conducive, then perhaps we can just close the skin only, leaving the uh,
yes,
uh, aponeurotic part open, right?
yes,
So
sir.
just wait for the this intra-abdominal edema and infections to subside, then perhaps we can close the sheath, right? So that is another option, to just close the skin, only the skin, right?
Okay. So this patient you have taken on OT table. Patient is resuscitated, and now you find it's a complete dehiscence. How are you going to manage it on table?
Sir, we did open the wound, exploratory
Yes.
laparotomy. Then
Why? Why?
we,
Why? Why an exploratory laparotomy is required? Why do you need a laparotomy in this patient who has got a burst abdomen? What do you like to exclude?
sir, we have to exclude any intestinal obstruction is there or not,
Yes.
any anastomotic leak is present or not, or any
And
intra-abdominal collection
collection.
is collection
Yes.
is there or not. Yes,
So
sir.
these are the patients who will require a thorough laparotomy. You exclude
Mm.
obstruction, you exclude collection.
Yes, sir.
And this is the patient under petty perforation, patient may have reperforation.
Reperforation.
Okay, nothing is there. No obstruction, no collection, only just a wound essence. How are you going to manage on table?
Sir, we give the thorough saline wash,
Yes.
peritoneal level, and the extruded bowel is replaced into the abdomen. All layer of
Yeah.
abdomen are approximated by interrupted through and through suture using a monofilament polyamide or a loop PDS, sir. Hello,
Anything else? What about the skin closure? Have you heard
sir.
of tension stitches?
Yes, sir.
Tension stitches. Have you heard about the tension stitches?
Yes, sir. A soft rubber tubing is there. The
Yeah.
suture material should be passed through that to allow a tension-free
So
closure.
yes. So all layers should be included in this tension stitches.
Yes, sir.
Right. So how do you propose to manage the post-operative period in this patient?
Sorry, we have to correct the dehydration is there or not by through intravenous fluid. Uh, we give nasogastric suction if abdominal distension is present. We put the patient in NGS tube and IV antibiotic started, broad spectrum antibiotic with both gram positive, gram negative, and anaerobic coverage. If uh, then sterile dressing should be done regularly, and abdominal binder may be used. Uh,
Right. Nutritional support. That is very, very important. Right.
yes, sir.
Nutritional support. Right.
Nutritional support. Yes, sir.
So
These
what
are
is
the patient, yeah, these are the patient who may develop uh, compartment syndrome. So in the post-op period, how will you diagnose the patient has got abdominal hypertension leading on to abdominal compartment syndrome? What are the pointers? You have closed, and now after anesthesia, uh, you now think that patient might have developed uh, internal hypertension and subsequently may lead to compartment syndrome. What are the pointers? What happens if you have done the abdominal closure under tension and abdominal pressure is high? What is going to happen in the post-op period?
The distension may be there, sir, in the
Nee, tight abdomen, you have
yes, the
closed.
tight abdomen. Yes, sir.
What are
And
the early features of internal hypertension? Early features are there is compression of infra vena cava.
yes, sir.
So these are the patient who develop oliguria. These are the patient who develop hypotension.
Yes, sir.
And what you do in hypotension? You give fluid challenge.
Yes, sir.
So what will happen? If you give the patient fluid challenge, what is going to happen?
Hmm. Sir,
The
it will-
hypotension may not get corrected. Try to
may not get
understand.
corrected. Yes, sir.
Rather hypotension may deteriorate.
Yes, sir.
How will you measure the interabdominal pressure? In the post-op period, what are the ways you can measure the interabdominal pressure? Simple. You could do it in the ward. We have done for one patient in the post-op period. How will you assess the intra-abdominal pressure. This can be done through the Foley's catheter. How? You know? So there are different ways to measure the intra-abdominal pressure. You can directly measure the intra-abdominal pressure by introducing a transducer into the peritoneal cavity and measure this through this transducer probe. That is one, but that is not usually done. The most commonly done is using the Foley's catheter. What you do is you empty the bladder, put 50 ml of saline through the Foley's catheter into the bladder, and connect this Foley's catheter to a manometer. You keep a manometer by the side of the patient. This will give a manometer will give the fluid column in the catheter, giving you the abdominal pressure. When is the alarm saying that yes, this patient has got higher abdominal pressure?
Sir, if
Beyond
it is more 25 mmHg, sir.
25 is too much. A patient will have severe.
That
8
is
to 10.
good.
8 to
Yes,
10.
sir.
More than 12 is described as abdominal hypertension. If you have
Yes,
more
sir.
than 12 mercury pressure, it's a abdominal hypertension. More than
Yes, sir.
20 will lead to abdominal compartment syndrome.
Compartment syndrome, yes.
So what
Okay.
will do if you suspect that patient might have abdominal compartment syndrome? What will the next step that you will do?
So we have to release the sutures so that the intercompartmental pressure going down, goes down, sir.
Yes. So stitches should be cut
Yes, sir.
and should be allowed to release the pressure within the abdomen. And
Yes, sir.
this patient are also sometimes have some respiratory difficulties, right? Because the diaphragm becomes it cannot move downwards because of the increased intra-abdominal pressure. So you
Yes,
might
sir.
need some kind of ventilation, maybe endotracheal intubation ventilations. Right.
Yes, sir.
So normally, how long, in case of burst abdomen, how long you keep the stitches?
So, sir, if it is the intra-abdominal pressure raises up to 12, we have to remove the suture, sir.
No, no. Otherwise, everything is under control, right?
Yes, sir.
The abdomen is now more or less settled.
Yes,
Okay.
sir.
So normally, at what time? In otherwise, normally at what time you remove the abdominal stitches? Suppose you have done exploratory laparotomy, everything's fine. Patient is taking orally, right? Abdomen is settled. So, what is the normal? Uh, procedures to take off the stitches, cut off the stitches.
But it should be removed after 10 days, sir. 10 to 12 days, sir.
Usually 7 to 10 days, right?
Yes, sir.
But in case of burst abdomen, how long you will keep it?
Sir, it should be keep up to 2 weeks, sir.
A little longer, right? So
Yes, sir. Longer, sir.
15 to 20 days.
Yes, sir.
Okay.
A little about basics. Prasenjit, when
Yes, sir.
you close the abdominal wound, you are closing skin, you are
Yes,
closing peritoneum, and you
yes,
are closing mesenchymal tissue in between.
yes, sir.
How the healing occurs? Is the healing same in all three layers or healing is different? How the healing occurs?
Sir, different, sir. Yes.
How? Describe. How the peritoneum heals, how the skin margin heals, how the intervening fascial tissue heals. You have to know this. In burst abdomen, the basic thing is wound healing and deviation from the wound healing.
So healing of peritoneum occurs primarily by re-epithelialization of the damaged site.
It's a mesothelialization.
Yes, sir. New
When it
mesothelium.
starts, when it get over.
Sir,
It starts within 24 hours, get
normal.
over by 72 hours.
Yes,
So
sir.
if you are keeping the peritoneum closed, this peritoneum margin heals by mesothelialization, which starts in 24 hours time and get over in 72 hours. What about the skin healing? Skin margin. In a wound which is opposed, the skin margin are closed, side by side.
Yes, sir.
So skin margin healed by,
So starts epithelialization start within 24 hours, sir.
yes, and the epithelialization, the surface epithelialization occurs by 72 hours. So you'll find
72
a
hours.
lot of people take the dressing off after 48, 72 hours. Because
Yes.
if the skin margin epithelialization is done, nothing will penetrate to this epithelialized area. So you can move the dressing.
So
What is the
because
mechanism of
what are
healing of the,
types?
yeah, yes. What is the mechanism of healing of the intervening layer? How the intervening layer heals? Same or different?
Sir, different, sir.
How different? So intervening layer is the mesenchymal layers,
Yes,
which
sir.
heals in stages. So what are the different stages of wound healing? What happens immediately after you close the abdomen? What are the different stages you describe? And the wound starts healing, then wound get matured, and wound regains its tensile strength. So they heal in stages. The first
Mm.
stage is hematoma formation. When you oppose the wound, there is collection of some amount of blood in the intervening area. The next step is what? There is infiltration of the wound by neutrophils
Neutrophils.
and mononuclear cells, which get converted into fibroblast. Next is what? The next step is in 7 to 14 days time, these fibroblasts starts laying collagen. These fibroblasts started laying collagen. And what is the characteristic of the collagen which is laid fast? These are mature or immature collagen?
The immature collagen.
Immature collagen. So
Yes.
once this starts laying this collagen, this wound starts healing. So
Yes,
as
sir.
you said, in 2 weeks' time, this wound margin is opposed by immature collagen, not mature
Immature.
collagen.
Yes, sir.
Then from 15 days to about 4 weeks' time, this uh, immature collagen started getting into mature collagen.
Mature collagen.
And this caused healing of the mesenchymal layers. What do
Mesenchymal.
you mean by tensile strength of a wound? How do you define tensile strength of a wound? You
So
applied, yes,
tensile strength is the force required to break the wound,
good,
sir.
good. So suppose you have sutured the wound, remove the wound suture after 7 days. Now, if you pull apart the wound, it will open up in seven,
Yes, sir.
8 days time. Does not
Yes,
require a lot of force.
yes, sir.
So if you take this wound healing mechanism, this tensile strength is a breaking point at which the wound breaks by force.
Yes, sir.
So what is the chronology of gaining this tensile strength in the wound if you go by period? Initially, 7, 10 days, minimal,
Yes,
because
sir.
all immature collagen.
Yes, sir.
Okay. At what period of this wound healing, 50% of the tensile strength of the wound is gained?
Sir, after 4 weeks, sir.
No, 4 weeks, 50% नहीं होता है. Okay.
Yes, sir.
50% wound strength is gained in about 6 months' time.
6 months. Yes.
Okay.
Yes.
At the end of 1.5 year, you gain the near normal tensile strength. So it takes about a year and more than a year to have the wound to go into his near normal. It will not regain his 100% tensile strength as in a normal tissue, but near normal tensile strength is gained in the span of 1 to 1.5 year. So that is important because if you are allowing the wound to heal, it heals in stages. And the
This
wound
part
maturation occur over the period of 6 months to 1 year.
This is a very, very important point to remember, particularly when you plan, sorry, when you plan to repair for incisional hernias, right? So in case of incisional hernia, one should not uh, make hurry to repair incisional hernia, because as sir
Yes,
said,
I usually don't repair before 1 year, unless, yeah.
so adequate strength should be, achieved by the wound, so as to the sutures has to hold nicely. So it's always better
Yeah.
to wait at least for a year before you take up a patient for repair of insulin hernia.
Unless there is other emergency, obstruction or
Yes, yes,
strangulation. Otherwise, one should wait for repair insurance. That is the idea of waiting, because you allow the tissue to get matured in the process of wound healing. Okay. These are, you see, it's a 10-minute exam. We have spent 40 minutes. So
yes.
there are a lot of things to be asked, but your approach is important. How do you approach the patient is important, that you give the patient time for adequate taking history, then what has happened, you should examine, and then go for management.
Right, this is very
Okay.
important. Don't jump into the opening, into the dressing. So
Yeah,
first you identify yourself, greet the patient, then ask what about his complaints, how he's feeling, any pain, vomiting, or any other problem. Patient has passed stool fetus. So these basic things you should do first. You should check the urine output and any drains and other things that should be, noted. And after that, then you also you see the blood pressure, the pulse and temperature. Have a look at the notes, previous notes, OT notes. Then you examine the patient who opened the wound or whatever it may be. Then you
yeah.
describe that way. Then the questions will be asked. I think that is a nice way of presenting your case in case of what wrong.
Well, yes, it's only five minutes. Now people doesn't give a lot of time. So 5 minutes, you have to impress the examiner, giving the basic things of this scenario. Okay. Thank you, Dr. Ghosh.
Thank
Thank you
you.
very much.
After the
Thank
thanks.
you. Thank you.
Thank you, sir.
Thank you.